Okay, welcome everyone. My name is Juliette van Hattem, and on behalf of Professor Wilde, Dr. Armin and Nienke Hofman, I would like to welcome you all to the second webinar of the webinar series of the ERN GUARD-Heart. And today we will have a really nice webinar which is titled and which is about the role of genetics for ICD decision in dilated cardiomyopathy. And I would like a special welcome to our moderator of today, Professor Sharon, Professor Hansen, who will present the first case, and Professor Wabi, who will presenting the second case. And this webinar is about the thematic area 2. Of notice, I also mentioned before that the webinar will be recorded and on-demand viewing will be available afterwards. And the chat is open for all your questions and during the whole webinar. So I would like to give the word to you, Professor Sharon, to open the webinar and be the moderator of today.
Welcome to all of you to this webinar that is organized by the European Reference Network on Rare or Low Prevalence Cardiac Diseases. So my name is Sharon from Paris. It's my pleasure to moderate this webinar. Today we will discuss the role of genetics for ICD decision in dilated cardiomyopathy. It's a challenging task. Because to distinguish high risk and low conditions for sudden cardiac death is still really a challenging issue. We know that the usual predictor we use is still limited. We need to have additional predictors to refine the risk and to optimize the decision. So today we will have two experts on board. I'm very pleased to have them on board. We will discuss clinical cases and then there will be open discussion. You will be able to put your questions through the chat, so don't hesitate to do that. And we can start. So it's my pleasure to Mark, who will start with his talk and the first clinical case. Jacob.
Thank you. Thank you so much, first of all, for the invitation. And also, I'll just share my screen. Do you see my full screen now? Okay. So again, thank you so much for this very kind invitation. My name is Jacob Hansen. I am a professor of forensic cardiology, but also head of inherited arrhythmia here in Copenhagen. And together with Philippe, I was writing the new guidelines of VA SCD, which I think is also the reason why I was invited here today. So it's a great pleasure to be here indeed. So I will start with a case. But before that, I will just turn your attention to where do we foresee that the onset of VA, ventricular arrhythmia, or SCD, is in DCM. And here in this figure that we is a central figure from the new VA SCD guidelines. We have tried to illustrate this both with gender, blue being male, red being female, and then also with the onset and whether it's polymorphic VT or monomorphic VT. And also here indicating that genetic is actually a risk factor for SCD, and I'll draw your attention to some of the recommendations. I'm sure Karim will also follow up on this later. So here we do think there's a special role for genetics and more prominent. Okay, so I will give you a case that's from our center. So in Denmark, we are a referral center. So this case actually starts some years ago in another hospital. So it was a case of a woman age 47, seen at the outpatient clinic at another hospital. And the reason why she was seen was really not herself. And this is something that we see more and more in our center, I'm sure also in others. It was the mother. Now, the mother was a non-ischemic dilated cardiomyopathy with ejection fraction of 15, but the age was 70. Okay, so this is already something that, at least in our national guidelines, then we say that normally this does not indicate that we want to do a large follow-up on this. But then there was some family history with 2 maternal uncles, so on the mother's side, with sudden death at the age of 40 and 50 with no autopsy performed. Then she came from echo, so there was ejection fraction of 50, which may or may not, of course, be pathologic. It was non-dilated, ECG was normal, New York Heart Association class 1. So the question for you would be now, in your experience and in your daily practice, would you do follow-up on this patient? And then maybe in light of this also, would you do a genetic test here? And maybe I can ask Philippe and Karim to make a comment here.
I agree that if we would not have the family history, probably the follow-up could be very, very limited, and genetic testing not. But the family history changes radically, I think, the idea. So in this context, in this familial context, for sure, I will continue follow-up, cardiac follow-up of the case. The female, I would not perform at that stage, but cardiac follow-up for sure.
And Karim, would you?
Yes, I agree with Philippe on the follow-up, because we can make the assumption that there's possibly one disease within the family, and that the disease has been extremely severe in some relatives, and that it may put the patient you see at risk for events such as sudden death. So follow-up, I think, is mandatory in this patient. And I would discuss genetic testing at this stage as well.
Okay, so what was done was no follow-up and no genetic test. So what do we know about, so this is the new flowchart that we provided in the guidelines for DCM. Here we provided, first of all, when to do CMR. So it's a DCM patients. So you could argue, is this a DCM patient or not? I don't think this patient would have gotten CMR in our institution. And secondly, also we provide now a new framework for when to do genetic testing. And I think here, if I'm not mistaken, none of these criteria are made for class 1 or class 2A in this patients. So anyway, the story continues now, because when we hear first this patient comes to our attention, it's 4 years later, spring this year, at the age of 51. She's sitting in her chair, and the 16-year-old son finds the mother sitting with agonal respiration and realizes that it's a cardiac arrest, and starts bystander HLR or CPR, sorry, and there's VF on EMS arrival, and after 4 shocks, she's in a stable rhythm, but she's intubated on arrival. So here we have also tried to provide some new guidance in our guidelines, because what we have done is provided a pathway how to do the diagnostic in patients with unknown. And you could say whether this was a known. Philip, he says he would have followed up on this patient, but at least she was not known in this scenario, so we could go with that. It's an unknown cardiac disease. And then we have provided a flowchart for how to look into or do the diagnostic of sudden cardiac arrest survivors, because indeed she survived. And what you can see here is, first of all, you have the sudden cardiac death survivor, then the ECG plays in. If the ECG shows very solid sign of STEMI, of course, you go for urgent angiogram. Secondly, you look into whether extracardiac cause was there. So, for example, you can have a bleeding in the brain or pulmonary embolism. So indeed, she received a brain scan initially, and it was normal. And then you do, and I think this is a very important point, and also for this talk, here we have highlighted that quite initially, you should collect blood samples. For at least in our hospital, and I think this is across the world, a lot of attention is put into, will this patient survive, and what is the anoxic brain damage? And often it is forgotten to collect the blood sample for genetic screening, because probably quite often you then would go to, let me just see, next slide, sorry. It's frozen. Oh, let me see. Okay, so here we go. So then, of course, you do the echo here. And in this case, the ejection fraction was 45, so already indicative of disease. And what is important, of course, if the patient doesn't survive, maybe due to long cerebral anoxia, then the blood sample, at least in our center, and I'm sure this is also the same across Europe, is less often collected anyway. So there was already an echocardiogram of 45. We performed then angiogram, which was normal. Then we performed a CMR, and the CMR, there was LGE. So therefore we stop further evaluation into primary arrhythmic diseases. So that's the flow charts, though, because of course, first you think of ischemic heart disease. Secondly, you think of structural heart disease. And thirdly, you think or you evaluate for primary electric diseases. So here we stopped by the LGE, and I'll show you why in a moment. The CMR showed ejection fraction of 40 with a dilated left ventricle and LGE positive lateral and inferior. And here what was initially a bit surprising, it was transmural LGE positive. But what you see later on, it's more epicardial and midwall. So I think, and I think this is also something that at least we are trying hard, is to ask the doctors who are describing the CMR, just described it without giving too much opinion on the diagnosis, because we see a lot of things, at least in the cardiomyopathy field, where if it was only, it would say transmural, which indicates MI. That would be problematic in such a case, because in that case, you will not go to genetic screening. Any thoughts at this point from the audience or from my co-chairs?
No specific comment.
Yeah, I agree with you that cardiac MRI is on one hand extremely useful to better characterize the pattern. but that unfortunately can be misleading because sometimes you have misinterpretations, and I think you always need to have a critical approach on the results as a specialist in the field of cardiomyopathy or as a cardiologist in general.
Okay, very good. So at this point, I think the question, and this is an obvious question now, or the answer is obvious, we should do gene test. So what we did was gene test, and what we found was a DSP gene and a class 4 or likely pathogenic. You see that it has not, I'm sorry, it's in Danish, but it has not previously been seen in GNOME AD. So that's 250,000 controls alleles. And it's in silico, it's a truncation, and it's predicted to be harmful. So that's how we came up with the class 4. Any thoughts? I think this is very important also. The bioinformatics is done in a multidisciplinary team. I think that's something that we have stressed also in the guidelines. So please also here, of course, it's a pretty strong, but yet that it has not been seen before or in the literature may sometimes make the bioinformatics more problematic, and sometimes it's a VUS plus in such cases. Okay, here of course is the pedigree. We should always have 3-degree pedigree in all these cases, and what you see, unfortunately, she has 3 children, of which we have not tested yet. The mother will of course be tested, and she's also positive. So overall, just a small comment on DCEM in the new guidelines with ejection fraction below 35, we have downgraded to a 2A, the ICD indication. But quite interestingly, in the group between 36 and 50, we have provided a new, and to my mind, of course, it's a good recommendation, where you see that between 36 and 35, if you have 2 risk factors, and these risk factors can be genes, although not the gene that I showed here, but what you will see RBM20, FLNC, and phospholamban. And then some specific on laminase, and I'll leave that to Karim. Yes. One last word would be, I think it's very important that we want this to be an expert multidisciplinary teams when we discuss this with our patients. In our clinic, it's cardiologists actually informing the patients about what a gene test may reveal. I think a special word, of course, is on the VUSs, and that also, I think in our guidelines, we also have provided that all class 3 or VUSs and class 4 should quite often or periodically be reassessed in order to either upgrade or downgrade, or of course, keep the same level. Yes, and I will not talk about this. I think Karim will do that. So take-home message is that a strong family history of sudden death may be DCM in the family. Ejection fraction of 50 may be first sign of DCM. Of course, it may be problematic, especially people doing quite a lot of sports. I think we all spend quite a lot of time figuring out whether it's pathologic or it's physiologic. And genetic plays an important and critical role in the management of DCM patients and family. I think that was it. And with that, a picture of our hospital. I'd like to thank you for your attention.
Thank you very much, Jacob, for this case and this talk. This case illustrates the importance of the family history. First, I think we should be very careful with the family history when we take care of the patient. And secondly, this illustrates very well the interest of genetics. I think the new ESC guidelines is really a great advance for refining the risk of patients in this area. And genetics is part of this. So there is a question about the listing of genes and why, for example, is not part of that. So could you comment a little bit on the genes that could be considered for this discussion?
Yes, I think so. We wanted to be conservative in this group. I think this is not a list that is final. This is work in progress. This was, written 1 or 2 years ago. We started, and the way that we did it was being very meticulous. So we ask all the primary writers of each chapter to start with the evidence. So to look up every papers that were out there and then provide that. And actually on all the recommendations, you will see that will be listed here. And then the supplementary, we have added that. Now, whether other genes could have been added, I agree. This is, of course, how should I put it? This is something that we had to align on a larger group. I do think that all of these 4, for sure, I feel very comfortable with. And that was, I guess, the reason why. So the threshold was set rather high in order for us to feel that it was correct. So, but I agree that more genes can be added. And probably also there can be some national experience that may differ.
I agree. I think that we should continue to improve the knowledge and the level of evidence for specific genes and so on. And one of the studies that was supporting this guideline was a meta-analysis of about 8,000 patients with DCM. So this highlighted, but this is a listing that should be reevaluated regularly. Yes. If there is no additional questions, I think that we will be able to continue the global discussion after the second talk. So we can probably stop here now. And it's my pleasure to ask Professor Karim Wabi to present the second talk and the second clinical case.
So, hello everyone, and thank you very much for the kind invitation. It's really a pleasure for me to participate to this presentation of cases. And I will present you the case of a patient I've seen a few years ago, aged 45 years, which had been referred by her GP after a first episode of paroxysmal atrial fibrillation. So when I've seen this patient, he has a completely normal physical examination. She had an ECG, which you can see here, with sinus rhythm and evidence of first-degree AV block with a marked prolongation. With a few supraventricular premature contractions. She had an echo as well, and the echo at this stage showed that she had an ejection fraction of between 50 and 55%, without any atrial enlargement, despite the fact that she had this history of atrial fibrillation. She had a 24 ambulatory ECG, which showed atrial premature contractions, but no sustained atrial fibrillation and no other arrhythmia. So at this stage, you can see that we had a patient who had the combination of atrial fibrillation, conduction defect with first-degree AV block, and normal ejection fraction, but the ejection fraction was close to the inferior limit of the normal range in a quite young patient. I'm aged 45 years old, so I consider this patient as being young. And at this stage, you can discuss several hypotheses, several diagnoses. The first one may be theoretically primary electrical disease or cardiomyopathy. And I think even at this stage, I think it's perhaps important to discuss if you have the hypothesis of a cardiomyopathy, of possibly an arrhythmogenic cardiomyopathy. And I think it's important to raise this hypothesis quite early because those patients have to be diagnosed because you have specific indications for ICDs, and this is what we discussed today. So my question would be at this stage, what further cardiac workups would you recommend, and would you recommend genetic testing?
At that stage, I think I would consider genetic testing, not so much argument, but underlying indication probably.
Did she have any other comorbidities? So maybe hypertension would speak against severe hypertension.
No, she had absolutely no comorbidity.
And the symptoms were, I forgot.
She just had palpitations.
Palpitation.
Related to atrial fibrillation.
I'm not sure she would be referred to my clinic, to be honest.
I saw her by chance. Another colleague was supposed to see her, and in the end, it turned out that I saw her, but she would probably not have been referred to me as a patient for a tertiary center. So I will add a supplemental information, which is obviously very important. I think at this stage, we can mention that when patients have atrial fibrillation, and atrial fibrillation is isolated, corresponds to lone atrial fibrillation, well, I think the likelihood that you have a diagnosis of cardiomyopathy or arrhythmogenic cardiomyopathy is relatively low. But I think it's important to mention that when you have AF plus evidence of conduction defect, then this hypothesis can make sense, particularly if you have borderline ejection fraction. So when I saw this patient, I had another information, which is obviously very important, is that she had a family history of dilated cardiomyopathy in her brother, and he had a severe DCM requiring heart transplant. Had not been mentioned by her GP, which is quite often the case. And I think it's important to mention, as you previously stated, that to be really systematic and to have for all patients with cardiomyopathy, suspected cardiomyopathy, a family pedigree, because sometimes you can diagnose, you can identify a sudden death, which sometimes is not mentioned by patients or by the physicians who can refer the patients. And if you take a look at the most recent recommendations on the prevention of sudden death, theoretically, for the potential indication of genetic testing, these patients does not fully fulfill the criteria for genetic testing because he didn't have really evidence of DCM, even if our ejection fraction was borderline. And at that point, I didn't prescribe genetic testing. I think I would do it now, but at that moment, that was not the first thing I did. But I arranged further cardiac assessments, and particularly a cardiac MRI. And the cardiac MRI confirmed the fact that the ejection fraction was close to 50%. And the cardiac MRI identified late ganglion enhancement in the septal area. To have a full characterization of myocardial involvement with cardiac MRI, which can be useful for both risk stratification for sudden death, as the ganglion enhancement burden is predictive of ventricular arrhythmias in patients with DCM in general and in various specific conditions. And because you can have sometimes clues for specific diagnoses, either inflammation or inherited myocardial diseases. And if you take a look again at the ECG in this patient, you can see that she has third-degree AV block, and first-degree AV block has been correlated in several diseases with fibrosis in the septal area. And you have also a poor progression of the airwaves of the ECG in the right precordial leads. So you have a quite good correlation between ECG and cardiac MRI findings. So at this stage, in the end, the patient had genetic testing. We used a large panel, which includes in our genetic department in Pitié-Salpêtrière approximately 70 genes at that moment. And the genetic analysis identified a pathogenic heterozygous pathogenic variant in the elimini gene, and the patient had a truncating mutation. I think you have all heard of laminopathies. Laminopathies are conditions caused by mutations in the elimini gene, autosomal dominant diseases, which have been initially described both in Europe and in the US in 1999. And LMNA variants are present in approximately 5% of patients with idiopathic dilated cardiomyopathy. And laminopathies are probably one of the most arrhythmogenic conditions. We previously discussed that. And patients have a very high risk to die suddenly and a very high risk to develop terminal heart failure. So the discussion for that patient was, is there a specific indication for an ICD? And this is once again what we discussed today. And I think in the most recent guidelines, it had been mentioned that the very specific MLA population has very specific criteria for the placement of ICDs. And there are two approaches available, which are really specific to that disease, for risk stratification and for the identification of patients who may be eligible for an ICD. You have a risk factor approach based on quite simple assessments, and several risk factors have been validated in this population. Male sex, evidence of truncating mutation, non-sustained VT on Holter ECG, and an ejection fraction of below 45%. And it has been shown that patients with no one or only one of those risk factors have a quite low risk to have arrhythmic events. And patients who have two or more risk factors have a very high risk to have ventricular arrhythmias and have a potential indication for an ICD. And more recently, our group has developed another approach, which is quite similar to that which has been validated in HCM and in other inherited conditions, based on a quantitative assessment of the risk for patients who have VTA at 5 years. They have developed a specific algorithm, and you have more or less the same criteria, but also evidence of atrioventricular block. And when you use this calculator, which is available online, you can see that this patient had almost a 17% risk to have an arrhythmic event. So quite obviously, she has an indication for an ICD. And the most recent guidelines mention that if you have a 5-year risk, above 10% associated with an ejection fraction of below 50% or non-sustained VT or AV conduction delay, then you have a quite clear indication for ICD, a class 2A indication. So I think this observation highlights the fact that at a stage where you have only the information of AF and third degree AV block, you have obviously no indication for an ICD. If you add in this patient the family history of dilated cardiomyopathy, I think there's obviously no indication for ICD. If you have the cardiac MRI findings, I think you have not sufficient level of risk to implant an ICD. And having the genetic testing finding puts the patient at high risk for some deaths. And I think there's a quite consensual indication for ICD. So you can see that there's a significant difference in terms of cardiac management indication for ICD between having a genetic testing done or not. And I can add that the genetic testing is probably interesting for other aspects of the management of the disease, particularly the stroke prevention. All patients with laminopathies who have evidence of atrial fibrillation have an indication for oral anticoagulants. And as we previously discussed, LMNA is probably the first gene for which it has been shown that you can have a specific approach to select patients for ICD placements. But we have now various studies with other genes associated with the development of arrhythmogenic dilated cardiomyopathies. And this was my last take-home message.
Thank you very much, Karim. I think it is also a good illustration of sometimes a difficult way to go to the final diagnosis of laminopathy or so on. And here we see a combination of several cardiac features that only one is not sufficient to go to the right diagnosis, but the combination of AV block, tight system dysfunction, atrial fibrillation, and of course the family history, then we will be able to go to the diagnosis. And interestingly, you mentioned in your case the MRI and the late enhancement in the septal wall. That is probably also a good feature that is a feature of laminopathy. The septal wall.
Yeah, I missed your last sentence, but yes, in patients with laminopathies, one of the first manifestations is the development of AV block, and it has been shown that quite often when you do a cardiac MRI, you find fibrosis, which is initially located in this specific area. And there are correlations in several cohorts between the fibrosis in this specific place and evidence of first degree AV block. And this, it seems that is probably a quite specific pattern.
One possible question is about the threshold for putting ICD. So it's always a difficult strategy, difficult decision, but you mentioned the score that you established, and that it's very useful to refine the level of risk. And indeed, in the recent guidelines from ESC, it was a mix between the level of the score and the presence of cardiac abnormalities that probably remain to be tested, this strategy, prospectively in a Levin patient, but probably a good compromise at the moment for the decision for ICD. What do you think, Karim, in your practice?
Well, I think it's the use of this kind of scores in laminopathies, but also in HCM, in IRVC, is quite a controversial topic. I think it provides significant clinical benefit for patients, because when you have studies with a head-to-head comparison between the risk factor approaches and the use of those calculators, you can see that you can reclassify a significant proportion of patients which are not diagnosed with the risk factor approach. And the question is obviously, where should you put the threshold? I think it's quite difficult. And it's difficult to make comparisons from one condition to another, because you have different studies, different events which are predicted. So we had this discussion together several times, and I think 10% is probably in laminopathies, and specifically in laminopathies, a good compromise in terms of avoidance of unnecessary ICD placements and sufficient sensitivity in the detection of events. And what you must keep in mind when you see a patient and you use a calculator is that you have a 5-year prediction. And generally, you see those patients on a yearly basis. So you reassess the risk every year. It's not as if you were in a position where you see the patient only 5 years. So 10% can seem to be quite high, but it's 10% at 5 years. So I think it's probably a good compromise. And one important point which has been mentioned in the guidelines, and I think it's important, is that you have to be very careful when you have asymptomatic carriers. If you have a patient with the male gender who has a truncating mutation, you have 2 risk factors, and you have at a young age a very high risk. So I think you should not systematically implant patients with an ICDs when they are in this situation. And I think it's reasonable, as it has been mentioned in the guidelines, to have also other signs of evidence of the expression of the disease in the heart, either an impaired ejection fraction or non-sustained VT or anything else.
Okay. Jacob, you want to make a comment or a question?
Yeah, I just wanted to follow up on Karim saying that, you know, when we did this recommendation, we also looked at what kind of outcomes were in the different calculators, and it has to be so for example in ARVC, there's in this risk calculator there are quite a lot of hemodynamic tolerated VTs, indicating that maybe first sign may in ARVC, at least in quite a few of the cases, be a hemodynamic tolerated VT, which give you time to actually then decide on an ICD. This is not the case for laminase, which is really was important for us in the decision whether to implement it or not. Yeah. In the chat, there's a question from Tom Robbins.
At the end, which patients with DCM should we perform genetic testing? Why not to all patients with DCM was possibly the question. Guidelines are expressed on level of recommendation according to the family history, the age of the patient, and so on. So what do you think in your practice about?
So I think it comes in two-way. It's a two-way question, because one thing I think is genetic screening and also follow up on family. And I think from Karim's case, we really saw that in a lot of cases where you have a young patients with DCM, even HTX, so heart transplant, they forget to refer to us, because of course the brother should have should have been the entry to this sister instead of that she came with palpitations. So that's one thing. And so young age, And then we have a cutoff of arbitrary of 50 if it's an isolated case in our country. But I think that the new guidelines really show some good, and I don't think it's the final word, but it's a good pavement to when to do it and not how to do it, which gene test. And I think in the consensus statement, it's which genes we should test. And what we specifically say is the four genes that we mention are important for decision making in ICD, because they're so important in your risk. And this is why we have provided these four. So I don't think the two documents are in conflict as such. It's to my mind, at least.
There is not so much difference between the two. I think that the priority should be given to young patients with familial context or young age. The two guidelines open the way to performing genetic testing in sporadic case, but with a lesser level of evidence and probably a lesser yield of mutation identification. To the extent we see, along with time, we see how we progress into the patients. So I think we should close, unfortunately. I would like to thank you both very much, Karim and Jacob, for this interesting webinar, and that illustrates once again the evolution of the knowledge, the refinement of the risk to several predictors, and here especially thanks to genetics. So thank you very much, and I would like to remind you that this is a webinar series that will set up every month, the final Wednesday of each month. So I would like to say to you that you will be able to register and to see the next webinars of the European Reference Network. Thank you to all. Thank you very much.
Thank you.
Thank you.